We have some time for questions. We don't have any in the Q&A box, so anybody online, please put them in there if you have any. I'd be remiss if we didn't thank our sponsors, Smith Nephew, Innovus, and DePuy Synthes. We sincerely appreciate the support in putting on this sort of educational activity, and you guys have been great partners for us. Let's start at the top. Chris, you talked about program and pathways. What was your number one administrative hurdle to building a program for outpatient arthroplasty?
I think it was buy-in. Until we looked at our own data, they weren't willing to invest the money that we needed to make this successful. And then once we showed how we could improve our outcomes and be cost conscious to the healthcare system, they really doubled down and helped us. And then once we had that and they saw how much money they were making and saving by our good outcomes, it just kind of exploded. So there was that hurdle that is always financial that we had to overcome.
Fair enough. And Ron, you talked about pain control. You guys have done some great work on that. I've noticed in the papers and when we talk at meetings and such, it gets a little bit religious in that everybody has their own cocktail, and that's that darn it, that's what I do. Can you take us through what has worked for you for folks on the call that may want to jot some of that down?
Sure, Erner scaling block certainly by the anesthesiologist or the anesthesia team in the pre-op holding area, and most of the patients do get Toradol at the time of surgery, so that also helps them. In the post-op period, we do a Tylenol dosing that's scheduled, as well as a anti-inflammatory. It seems like in our system, meloxicam is like the Kaiser vitamin, so it's a Celebrex light type thing. So Kaiser must have a great contract on. It's cheap. And we then move into a gabapentin single 300 a morning, as well as a steroid, just a 3-2-1, a very light sliding scale of that. There are some GI meds, and then the narcotic is usually dosed, and it's there are multiple choices, but all of them are capped at like either 20 or 30 pills. So people don't get a lot of narcotic, and we've really walked away from refilling the narcotics. And I do a little bit of time to speak to the patients preoperatively about the fact that it's very rare that I refill the narcotic. They have to that's that kind of pain, surgery hurts type of discussion, that they need to know that they're going to have to kind of get ready for a little bit of achiness. And patients by and large don't need refills. It's just amazing. And so it really pushes me to want to do narcotic free regimens. I haven't done that. I hope that's enough detail you wanted.
Yeah, that's excellent. We got a question in the chat of, do you have the patient pick up the pain meds prior to surgery?
Yeah, I do. I tell them, pick them up the day before. I tell them, if you eat these before and say, oh, guess what? I ate them all, I need more, I'm not going to give them to you.
Got it.
I'm not in private practice. I don't need to impress anybody. There's a lot of people coming through, and so I just give them the clean deal.
Grant, I've long been a fan of the calculator that you guys have put together for patient selection. Do you ever find yourself needing to whip that out in clinic and like explain to a patient like why they may be better in an outpatient setting versus an inpatient setting, or how do you employ that in your practice?
Thanks, Quinn. So first of all, the Duke team gets a lot of credit for that, but it's been an honor to be a part of it. I think the key is a couple things. One is, when you're kind of starting to look at outpatient appropriateness or 90-day readmission rates, et cetera, it's helpful. But then as you kind of get used to it, you just kind of have that doorway diagnosis like Gestalt. That's sort of number one. Number two is the conversation for outpatient totally changed in 2020 with COVID. It used to be, oh no, my Medicare my insurance pays for me to be inpatient, and so I want to be waited on hand and foot in a hospital, and I don't want to do things on my own. I want to be in a hospital. And then as soon as COVID hit and people were afraid to go to that setting, people were begging for outpatient. So it really is not a hard sell, so to speak, now. And I think that, as often is, the hip and knee folks have kind of paved the way. So many of these have been done outpatient. Say, oh yeah, I had my hip and knee there. Well, this is even easier. You don't walk in your hands, so let's do it. So I think I would say the calculators are very helpful. I use them, but I use them less and less because it's just not necessary at this point.
Gotcha.
Quinn, so I have a question for this about how outpatient is your outpatient? Meaning, is this an OR that is attached to your office that is very far from any hospital, or is this just an outpatient case being done at the hospital that you're sending home the same day? Because I think that these are very different circumstances, right? Because you could have a very effective outpatient program. But if it's being done and you have the full hospital system involved in navigating with nurses and doing all these different things, that's very different than being in private practice and working at a surgery center where you are the system that you have to create, right? So, Grant, is your outpatient stuff done at a surgery center that is right across the street from a hospital or in the hospital? How do you do it?
Yeah. So to answer that, it's a freestanding ASC that I'm working at. One of them is in downtown Chicago, so Northwestern ER would be like a block away, right? And one of them is, but it's not attached to it. It's in a totally separate building. One of them is in a more suburban location where a different level 4 hospital is like a mile away. So they're not attached to hospitals. They're freestanding ASCs. I think the second thing to point out is the data that Chris Clifto and I both alluded to about the study looking at who can go outpatient. That was done in an inpatient setting, and then we looked at who was able to leave the next morning. So it's important to note that we then extrapolated, hey, the people that had their surgery and left within 24 hours are probably the people that would be most able to do outpatient surgery. But that study was done before this was approved. So that was the only way to look at it.
I don't know whether to be inspired or embarrassed by your Excel sheet, because I don't have your level of grit to do that. And so for those of us who just cannot bring ourselves to sit down and do what you do, do you have any advice on vendors? Have you guys investigated any of these programs like Patient IQ or Obaird, and do you have a recommendation or thoughts on them?
Yeah, so first off, Quinn, I'm sure you got way more grit than I do. I think that's a great question, and there's a bunch of different ways to do this. So certainly, we've investigated Patient IQ. They do a great job. Hats off to Macatellis and their team. And there's some benefits that you get with them. Obaird, I think, also provides a really great product, and we've investigated them as well. There is substantial cost with both of them. If you're looking for a lower cost thing, many institutions have access to REDCap, and REDCap actually can do this for you. It takes some setup, and part of the reason we particularly didn't want to use REDCap is I don't love the amount of setup and like how tied you are to that one particular product. And then the other reason why, and this I think is probably the direction in which most people are going, is if you have Epic, all of your patients have MyChart to access their EMR. And I'm sure even for people who aren't using Epic, if there's a patient portal, your patient has access to the records, because patients use them all the time for renewing their medications and making appointments and accessing their notes and accessing their labs. So like my patients all have access to MyChart. So the direction we're moving right now is to have Epic collect this for us, because we can get better. Like the patients log in, they say, oh, I have a survey to complete. They complete their survey while they're doing something else anyway. They already recognize like that email that comes from my chart. And if it just says you have a new survey complete, they log in anyway. So that I think ultimately is what's like ultimately once Epic completely gets their act together, they're going to eat everyone else's lunch because they have that home ground advantage. So we're moving that direction at my institution. It's been a challenge because at least our instance of Epic did not have ASCS built in, so we have to like custom build that. So like these are the kind of clunky things that I think Epic's going to figure out in the long run. But I think if you were to make the long-term bet, that's the bet to make. If you want the cheapest bet, I would go with RedCap. And then I think if you're looking for someone who's all in, where you're willing to spend a little more money, then Oberyd and Patient IQ are really great providers.
Hey, can I
Excellent.
riff on this? Just ask Peter and the rest of the team. Well, when Peter said he was making he has his own personal list. I just started on my phone working with Claude, Anthropic, Claude, and I was seeing if Claude Cowork could create an agent to do all this work. They'd phone call the patients and do everything. And it was really interesting to see, like, the big issues are the HIPAA and plug back into the EMR of choice, whichever your company is with or whatever your private practice is with. But I think in the future, I believe the costs will go down because there'll be an artificial person calling and either emailing or texting or talking to the person as a hologram. What do you guys think about that? Like, just to move this forward.
Yeah, I look, I can't wait for that future. My understanding is that currently it's not legal for you to share any protected health information through any of the currently available AI solutions. I think there will be solutions in the future that allow that, but even within like we have, for instance, like an EDU version of ChatGPT that's like behind the firewall here at the U, and even that we're really not supposed to share PHI with. So I'm excited for that future. I don't think that exists currently.
Okay, I think a frequent question we all get is about cost control and implant control because as you pointed out, that's responsible for so much of the cost. There's several methods to try to contain implant costs. How have you gone about it at Duke?
Yeah, that's a good question, and it is the most important thing. I think at Duke, we moved to a sort of tiered vendor system based upon what the physicians were currently using, and then negotiated with the companies. Initially, it was supposed to be a two-tiered system, so we picked two systems we liked, and then we expanded to three systems. And then based on that, we were able to negotiate significant savings. I think we ended up saving the institution over $2 million in the span of about 2 years. But we were also somewhat incentivized in a unique way because we were sort of gaining in the savings. 25% of that came back to our section to be used for academic purposes, obviously. So that worked very effectively. It was a 3-year contract. So, you lower your costs, and then your contract runs out. And, the problem is you get to a point where you just can't lower it anymore. And if you really want to continue to get the savings and whatever you're going to do with the savings, you have to then find other vendors. So it's not a foolproof system. But in general, I think consolidation is key. I think shared alignment amongst providers is key. And that's usually a bit harder when you get into these academic centers where there are all kinds of relationships. But that is usually the biggest way I know to sort of manage costs from implants.
I had a very sarcastic response lined up for your $2 million savings, and then you said you were smart enough to do gain sharing. So that's really well done.
Well done on that. I wanted to ask another question about staying along the same theme of how outpatient is your outpatient, right? Chris, for your patients that are having outpatient shoulder arthroplasty, are they being done in a place where they have to go home the same day? Because
Yeah,
these freestanding surgery centers, not every state allows for a 23-hour sleeping bed for these patients.
we have two models and pathways. I guess we have three. One is just a straight inpatient. We have a second bedded outpatient pathway where and these are like our tweener patients who are able to stay if they have to, but the plan is for them to go home. And then we have our straight ASC pathway. And we work with our preoperative colleagues to help us decide which patient fits in that pathway.
Serena in Philly, are you locked in? If you take the patient to the freestanding center, do those patients have to go home the same day, or do you have a overnight opportunity there if you needed it?
Yeah, so at all of our ASCs that perform outpatient total shoulders and hips and knees, so all of the ASCs that are kind of what I would call standalone ASCs, they're for the most part affiliated or right across the street from a hospital. And so the patient, if there's an issue, can get moved across the street. Our specialty hospital, they can stay overnight. And then some of our ASCs do have a 23-hour allowance. So it's variable.
I think it's important to know, though, is that I believe most states have laws where you have to have a transfer agreement with a hospital from an ASC if it's a freestanding facility. So any physicians that are on the webinar tonight that are doing this and are early in their freestanding ASC experience or they're building one, that's an important component of what you need to have.
Yeah, but that's also hard because at least at our institution, we have to call EMS and it's right across the street. So it's a huge cost and such a detractor for our healthcare system when that happens. So
It's bad optics,
yeah,
right? I mean,
yeah, it's like the patient can't breathe from a block and we're putting them in an ambulance. So
right.
Well, Howard, mine's ASC is like 5 miles down the 405 without anything. So in California, everything is so fraudulent and disrupted that it's hard to even get an ambulance. So that picture of Larry Gulata's bleeding was really freaking me out, you know?
It's pretty traumatic to see that. I hope it was a staged event that and you got to give Larry credit for his acting. Yeah, our outpatient surgery center is not anywhere near a hospital, and it does not have 23-hour capacity. So the patients that we take there are patients that, they're going home on the same day. And so we have to be very selective.
So Rena, let's finish up with you. You really outlined very nicely how the incentives line up for all the players in private practice. What would you say right now is your biggest pain point when it comes to outpatient shoulder arthroplasty, regardless of the setting that you're doing it in?
To be honest, I don't think we have huge problems with getting patients through the process. I think that was an issue maybe 3 to 5 years ago, and all the work that's been done by everybody on this call around the country and all the messaging that's been done with patients and the hospital system has really helped to solve those problems. I think the biggest thing that we have seen is we are doing less and less shoulder replacement at the hospital, and we're doing less as a practice. We're doing less and less hip and knee replacement at the hospital, and we're doing less and less spine surgery at the hospital. And so those hospitals have OR availability and they want to fill those ORs. And so it does lead to some tension between our practice and the hospital in terms of, do they need to hire their own orthopedic surgeons to bring more cases into their facilities that are in some ways losing volume. And so I think that's the biggest struggle that we have, and how do we manage that relationship?
I think that's a good point. I mean, you and I have pretty similar practice environments, and I think OK touched on this a little bit too. When you have a fully physician-owned ASC, you're responsible for the insurance contracts, and that is our setup, and that is our biggest headache, is fighting with a very diverse set of insurers here in our region, trying to get all the contracts in line and knowing who's approved and who's not. Well, I think we've hit everybody. Howard, do you have any more questions? I don't have any more in the chat box.
Well, my biggest pain point is the social component of this. You may have an ideal patient that's perfect for outpatient, and then you haven't really done a good enough job digging into their social circumstances and find out, relatively, late that I forget who said that basically having a man at home is essentially the same as having nothing at home. That was you, Grant, right? Yeah. So I think the social component of it is one of my biggest pain points. And great job, everyone. This is a beautiful educational experience for me.
Can I just ask a question? A very simple question. For those of you who have your guidelines, is there an age at which you will say, I cannot do your surgery as an outpatient? You need to stay at least 23 hours. Is there any age? Is it 90? Is it 85? Or can they go home if they're a 90-year-old having a total shoulder? Because I'll say for me personally, I feel a little weird as patients get into the 75 to 80 range. I worry about them falling. I get a little nervous about sending them home the same day. But I'm just curious if I'm just being a little bit, too cautious.
I I I think the oldest I've done outpatient is 91. And
Okay.
that sounds ridiculous, but I'm a huge believer that like patients vary dramatically. I mean, you've all seen the 56-year-old that looks 85 and the 87-year-old that looks 56, and I I personally just don't think that like a specific number is necessarily something that makes sense for patients. But I could.
In Memphis, if you're 90 and ready for a shoulder replacement, you have been naturally selected where I'm not going to be able to do anything worse to you than your environment hasn't already done.
I always tell patients too, like, what's sleeping overnight going to do for you that a nurse never visits you once the whole night? You're going to go home the next day anyway, so go home today.
Yeah, with pain no longer being the main reason that people are in the hospital for this, and if we have elderly folks, if they're peeing and walking and eating and giving the nurses hell and feeling fine, there really is no reason for them to be there. So we set it up as the expectation is that they're going home the same day, and you can tell immediately who's going to spend the night because when you say that and they go, "Oh no, no." They're spending the night because they have their own personal expectation.
All right, guys. Well, that was a fantastic session. Really appreciate everybody's contributions. Again, thank you to our sponsors and thank you for everybody online for attending. And hope you all have a great night.